So welcome. I'm happy to have each of you here. We're going to talk today about hormones and most specifically actually about women's hormones and how they impact overall health. And maybe we'll raise some questions. That's actually a good thing if we do. I often say each of us, in being the best advocate for our own health, needs to be empowered with good questions. So both in raising questions in this dialogue that we have today, that may lead you to have things you can ask your own healthcare provider, or if you want to come in and work with us as a member, this is the kind of work that we do with each of our members to achieve good hormone balance and overall health because of the impact that hormones have on the entire system. I'm Dr. Jeralyn Brossfield, and I run my clinic called Exo Health. Kirsten Foster, who's on the call today with us, is my assistant in the office and navigates our patient's experience. And so you may be able to ask her questions, certainly if you call into our office. And I'll give you my phone number at the end of our time together as well. I'm going to move to sharing my screen so that you can see a couple slides and we start this discussion. As I do that, one of the things I just want to set up is that if we look at the lifespan, in fact, I'll wait on sharing the screen for a moment. If we look at the lifespan of women and men, usually puberty happens in our early teens and we start to make hormones because of a magical cascade of hormones that are created at that time that then turn on our ovaries or testes if we were a guy. And when we start making hormones, there is a finite or a set number of eggs in our ovaries that every month as we go through a cycle will actually be stimulated to make hormones for us for essentially the next 30 days. So every time a woman ovulates in the middle of her cycle, that egg that ovulated has the capacity in its little bubble around it to make the progesterone for the rest of the month that we need. And when we don't have good quality eggs, so what tends to happen is we've been having periods for longer and longer, and then we get close to menopause and into our 40s, we will have eggs that they're literally not good eggs. They're not as good. And the way that expresses is that they will not make progesterone as effectively for the remainder of the month. And when they don't make progesterone effectively after we ovulate, we then have symptoms that we've labeled in our country. We label it PMS or PMDD, which are both premenstrual syndromes where we don't feel as good for those couple weeks before our period. And it's generally because the progesterone quantity that our eggs were supposed to make to sustain us until that next period is falling off. When we get ready to go through menopause, not only are there more of those bad eggs, but we also don't make testosterone as effectively. And so typically we'll have a decrease in testosterone first, generally sometimes starting late in our 30s and early 40s. And then the progesterone quality and quantity tends to drop off a bit. And then eventually as we get closer to menopause, our estrogen quantity actually is not created as consistently. And as estrogen is not created consistently, we then have changes. And one of the things I'd like to sort of maybe open our perspective on is that we tend as women to think that estrogen's main effects are going to be around things like hot flashes and night sweats. As far as if I was lacking estrogen, what would I feel? And many people would say hot flashes or night sweats. The thing that's kind of interesting is really about 50 to 60% of people have that issue, which means about 40% of women don't ever have a night sweat or a hot flash. So when we think about those dropping levels of estrogen as we get towards menopause, we really have a variety of symptoms that can happen that don't have anything to do with night sweats or hot flashes. And those symptoms tend to really be more in the realm of connective tissue and the impact on collagen and connective tissue in our body. So a lot of times those symptoms will exhibit in things like joint pain. Joints get uncomfortable when estrogen is low, mainly because the collagen isn't as plumped up and padding our joints as well as it did when our estrogen was high. So joint pain is one of the things I query when I'm talking with women about hormones as one of the main harbingers to me that estrogen levels are low. Another thing that estrogen impacts is our blood sugar metabolism. And so if blood sugar is not staying as stable, that's another sign to me that estrogen levels are not as stable. In fact, one of the beautiful things about estrogen is that it's very preventive for diabetes. So I use estrogen balance as one of my techniques to help people prevent diabetes when we're looking at overall health. Another area that estrogen impacts quite significantly is elasticity of connective tissue. So whether that's of joint padding or of things like our blood vessels, where the blood vessel walls are supposed to be extremely elastic and they're supposed to be dynamic, where, you know, if I were to jump up from this chair, my blood vessels are supposed to squeeze so that I keep my blood pressure up as I change positions. But if they don't do that, we tend towards high blood pressure, and lowering of estrogen levels at menopause tends to lead women to have more high blood pressure as well. So there are a number of things, and I see a question popping up. So I'm going to, in this time, I'm going to take questions as we go through, since we're going to have a harder time coming back to them without a slide to reference. Carrie, did you have a question? I see a question there maybe about the estrogen levels. And if so, unmute yourself in the lower left corner of your screen, and so that we can hear you to ask that question, Carrie. When I look at the impact of estrogen and other systems in the body, not only does it impact our blood pressure, not only does it impact our joints, not only does it impact our hot flashes or our temperature regulation, but it also impacts what I think of as mucous membranes. So our mucous membranes in the body include our mouths, our eyes, inside our nose, and inside the vaginal tissue. And each of those areas is meant to be moist and basically elastic and not dried out. And so estrogen is extremely high in its receptor density in those areas because estrogen tends to keep those tissues functional. And so even one of the ways women often will ask me, does this have an impact, is does estrogen impact the collagen in our skin? And the answer is yes. Women who have some estrogen in their system actually have better collagen quality in their skin over time as well. Carrie, did you have a question?
I just got here.
Oh, good. Hi.
I mean, I just made it work.
Oh, perfect. Good. I see that you unmuted yourself, and I was trying to figure out if it was that you weren't hearing us or if you had a specific question. That's perfect.
I'm sorry. Now
Welcome.
I was on time and now I'm late.
No worries. I'm glad you can hear us now. We've just been recapping the impact of estrogen in the system.
Oh, that's just what I wanted to hear.
Okay. So I'll summarize the things that we see estrogen doing the best. It tends to prevent diabetes or make our blood sugar more stable. It also tends to help us with collagen. And so I was saying that skin and our joints, and in particular the blood vessels that all have collagen in them, are balanced by having plenty of the estrogen present, because it keeps that muscle able to be elastic and able to squeeze appropriately. So for instance, I gave the example, if I jump up out of this chair, it's the blood vessels that will squeeze to keep my blood pressure from bottoming out as I change position. And estrogen has a really strong impact on keeping blood vessel elasticity normal. It also is extremely impactful in our mucous membrane. So moisture in our eyes, ears, nose, and vaginal tissues is maintained by estrogen as well. And then, of course, we know of temperature regulation like hot flashes and night sweats that are impacted by estrogen. The one other area I'll mention that estrogen impacts is mood. And it's interesting because there's been study after study trying to prove whether estrogen is sort of an antidepressant or how it impacts women. I call it the joy hormone, and maybe that's a little over dramatic, but you know how when you wake up in the morning, there are some times where you wake up just with a sense that you're happy to be alive. The world is a good place and you're glad you're in it. That is the feeling that estrogen tends to impart. And so when I have patients who are coming in with just a little bit of, they'll often say, it just feels like there's a gray cloud over my head, or I'm not depressed, but I'm not happy. I'm sort of just kind of down, but I can't put my finger on it. that often is a clue to me to look at their estrogen. I, for years, had a front desk person at my children's school who I would walk in, and there were many times where I would walk in and she would look at me and just burst into tears. And I said, I'm so sorry. But we figured out that the issue was that when her estrogen was low, she was extremely tearful. And I've since then noticed that in patient after patient, we can use tearfulness as a gauge around estrogen. And it's not that other things in our lives might not also have to do with tearfulness, certainly. But if we're consistently more tearful than normal, or if, or also if we're a little bit more irritable than normal, those are estrogen related symptoms that I would want to know about as your physician, or if you were talking to a healthcare provider, you might want to give them that information. I'm going to move to our slides for a minute here. Just a moment. One of the sort of interesting things that will be forever marked in my memory is that when I opened my practice in the desert, which was 2002, there had been a study that just had come out that was about estrogen, and it was called the WHI study. And I'm going to ask, Carrie, can you mute yourself in the lower left corner of your screen? It'll make sure we don't have feedback on the call. Thank you. So in 2002, when I opened my practice, there was a interesting timing of when I opened my practice, and that was that there was a very, very large study, 16,000 women that had been in a study called the Women's Health Initiative, the WHI. And in the WHI, there had been women placed on hormones starting at age 50 all the way up to age 79. So these 16,000 women were of quite variable ages. Their average age was 63. And 5 years into the study was stopped because they were seeing more heart attacks and more breast cancer in the women taking Premarin and progesterone. They were taking Provera as the form they were taking. And so that study was stopped. Well, that study, when it was stopped, hit our newspapers with a headline that said, 26% increased risk of death if you take hormones. And I had opened my practice 2 days before that headline hit. So it was kind of a wild and woolly time, because the phone started ringing with women having questions about their hormones. And so that's what I'd like to spend the remainder of our time on, is some of the pros and cons with hormones, because the world really got tipped into some disarray at that point. Up until that time, we had thought that putting women on hormones was across the board beneficial, and that it would prevent heart disease and also help bone strength, and really made life much easier for women. And since that 2002 study was released, we've had what we think of as a pendulum swing, where the pendulum right then and there with that headline, literally half of women went home and flushed their hormones down the toilet. But since then, the pendulum has gone back and forth and back and forth, and I think at this point is settling into a much more moderate middle ground, although you will still hear huge controversy around hormones, and you may have a physician who says, I don't want you on hormones because of that study. And without being snotty, one of the things I often say to patients is, I wish that we could ask that doctor, have they read that study? Because in reading the study, the very last line of the study said, this information should not be taken to apply to clinical use. More study is needed. And yet, 50% of women flush their hormones down the toilet, and physician after physician has advised women to not use hormones based on that study. So I want to talk a little bit about the pros and cons of hormones and why there is such controversy, and why, just to be really clear, I am very pro-hormone, but I also would say that every person needs to evaluate their own situation, because there are nuances to this conversation that will be different for every person. The reason I say hormones are the missing piece is that they impact virtually every system. When I say hormones in this context, I'm thinking of estrogen, progesterone, and testosterone. And the most controversial hormone of those three has been estrogen. And so I want to go through some of the impacts of estrogen that that we can sort of gauge why am I pro-estrogen? Why would I say that personally I take estrogen? I'm now in menopause. Why do I take estrogen? Why would I say women should take estrogen? Why would I consider keeping a person on estrogen for their whole life? And so I'm not defending that per se, but I want you to understand why that's what the perspective I carry is after having evaluated the literature and having gone through the pendulum swings of the last, even 20 years on hormones. So this is a slide actually that was printed in an endocrinology journal in 2016, giving us just a relative comparison of women who take estrogen versus women who don't. And so if we look at the blue lines in this slide, everyone in the blue line would represent a woman taking estrogen, and the red would be someone who takes no hormones. And you can see that the variation between these two is not huge. I'm going to look at breast cancer first, where the risk of a woman being diagnosed with breast cancer is about 25% more. So it's a little, and if you look at the slide, you can see overall in our lifetime, we have a risk of being diagnosed with breast cancer that's something in it's about 18%. And if we don't take estrogen, it's a little bit lower. So then it's more like 13 to 15%. So you can see there's a slightly increased risk of being diagnosed with breast cancer if we take estrogen than not. From a standpoint of hip fractures, there are less hip fractures in women who take estrogen. It's almost even for stroke risk, one way or the other. Coronary artery disease or heart disease is much lower in women on estrogen than in women not on estrogen. In fact, that 0.65 relative risk means that there's about a 35% reduction in coronary artery disease if you take estrogen than if you don't. And then you can see that overall life expectancy is a little higher in women who take estrogen than those who don't. And the one bar that's not in this particular article that I want to mention is Alzheimer's, because Alzheimer's risk, if we were to look at bars just like this for Alzheimer's risk, it would look almost identical to the one for coronary artery disease. There's a 34% reduction in Alzheimer's incidence in women who take estrogen versus those who do not. So if we were to look at this list and say, what are we protected from by taking estrogen replacement after menopause versus what are we at risk for because of estrogen after menopause, we would say that the risk of breast cancer is slightly higher. It's about 25% higher by taking estrogen than not, but that the risk of hip fracture, coronary artery disease, and Alzheimer's are all reduced by taking estrogen, and our life expectancy is increased by taking estrogen, and stroke is kind of a dead even situation. So that makes me then say, so how would we use that information? Well, one of the things that we can do is sort of look at our own family history and our own risk factors. So I'll use myself as an example, but we could use any person. My family history has higher risk for coronary artery disease, breast cancer, and Alzheimer's are the three things that my family risk would make me think I might want to pay attention to. And so I have to look at the difference between those beneficial areas of benefiting reducing Alzheimer's and reducing heart disease versus the increased risk of breast cancer. And it's not uncommon that we have a mixture like that. We've got a good thing and a bad thing that we're evaluating between. And with breast cancer, one of the things that we know is that our risk of dying of breast cancer as a woman in the United States is about 1 in 8 for the last several years. However, if we look at our risk of dying of heart disease, our risk is about 52%. So half of women in this country, a little more than half, die of heart disease, whereas with breast cancer, it's much more like a 4% chance in our entire life that we would die of breast cancer. And with Alzheimer's, I don't know the statistics in that same framework, but we know that the reduction of risk with Alzheimer's would certainly be impactful if we were trying to evaluate that in this whole, kind of algorithm. So I will tend to look at the things that are the biggest risks and say, how do we protect for those? And so in a conversation with any one of you on the phone, or if you're talking with your physician, it's worth weighing the risks of, am I more at risk for breast cancer, or am I more at risk for heart disease or Alzheimer's or stroke or a hip fracture? Because that personal evaluation is going to be important in making a judgment call for yourself. And then there are some other impacts that I'll come back to, actually, about blood clotting risk, or other reasons a person might not use estrogen that would need to come into play that have to do with genetic predispositions. There's a mutation called MTHFR that I want to talk about, and I'm also going to come back and talk a little bit about blood clots. So if I go to the next slide, I want to just give you a little bit more information why estrogen is protective for heart disease and for some of these other areas that we find estrogen to be such a positive. If we have blood vessels that are nice and basically smooth on the inside, there's no what we would call dysfunctional endothelium, which is what's on the far right here. The dysfunctional endothelium means that we have a lining of the blood vessel that is very inflamed. And what we know is that estrogen receptors tend to be decreased in women who are not on estrogen. And in that connection, we see more progression of plaque across the artery wall, where this little fibrous cap or this layer of fat or cholesterol gets deposited into the wall of the blood vessel. And it literally sits between the muscle wall and the lining, this endothelial lining, and we'll have this plaque deposition there, which we see happening with much more consistency in women who don't take estrogen. The reasons why are fairly complicated. They're sort of listed in this, this box, but essentially estrogen benefits the blood vessels by allowing them to have more nitric oxide, which is one of the vitamins. If you take niacin, for instance, it's because it works in the nitric oxide pathway, but the blood vessel being able to dilate and constrict is very impacted by estrogen receptors. And that allows the blood vessel to really react better to the environmental stimuli of the person changing movement or being stressed or having impact of, even, for instance, foods or things that might change our blood flow. So because of the vasodilation being easier when we have estrogen present, we don't deposit plaque as well. The blood vessel, it's almost like imagining something that is moving being a harder target. That blood vessel moving basically keeps it constricting and expanding and not allowing as much plaque deposition into the wall. And there's a huge, huge impact on lowering inflammation by having estrogen in the system that allows us to not have a lining of the blood vessel wall that would allow cholesterol to move through and deposit itself. The lack of deposition, if we don't have cholesterol deposits in our blood vessels, they will never rupture and cause a heart attack or a stroke. And so it's really around the prevention of plaque deposition that estrogen has this beneficial effect towards heart disease. For blood pressure, estrogen's beneficial effect is because it keeps the muscle being easy to contract or relax. I want to talk a little bit more about breast cancer risk, because this is the fear area that most people have when they look at using hormones. And I want to compare. You can see, if you can read across the bottom of this slide, if there is a reduction in risk, the blue bar would go below 1 towards 0. And if the bar goes up above that line at 1, it means there's increased risk. So the increased risk of breast cancer, and this is based on that large study I was talking to you about, and these were the medicines that women were on. They were on conjugated estrogen and medroxyprogesterone, which are synthetic hormones that, in all honesty, we use much, much less. I can remember writing one of those prescriptions once in the past year, whereas I've written a lot of estrogen prescriptions for bioidentical estrogens. So irregardless of the form, even if we look at this combination of estrogen and progesterone, this was the amount of risk, the relative risk that increased because of use of hormones. So it went up very slightly. It went up 0.025 in that study that I'm talking about from 2002. if women took estrogen by itself and they weren't taking this synthetic progesterone, there was actually less breast cancer. And those would be women who had had a hysterectomy and were not taking any progesterone. So they had a lower incidence of risk of breast cancer. And then this is a comparison of the risk of breast cancer in these different scenarios. So a flight attendant right here has not quite double the risk of breast cancer, but she does have an increased risk of breast cancer because of radiation. And so one of the things that we know is that the more that we fly in planes across our country, around the world, particularly the closer to noontime that we fly, the higher the radiation risk from the sun. This is the increased risk that would be present from being a flight attendant. And I'm sorry that I can't see to mute you right now, but if someone's talking to someone in their environment, just go ahead and mute at your lower left corner of your screen. This next bar right here is increased weight. So this is the impact of obesity or even a mildly overweight impact on breast cancer risk. This next bar says late first birth. This one would be any women who have had their first baby after the age of 30. So in my case, for instance, that would apply, and many of us might know that in our own situation. This is the benefit and or increased bone density risk from being on estrogen. And it's interesting, if you look at what we want from estrogen, increased bone density is actually what we want. So this is a good thing. And so in some ways, it's another area where you do your risk-benefit ratio to say, is my increased bone density benefit really something I'm willing to go ahead and take estrogen for? Because we see that it does have the risk, so to speak, of increasing bone density, which is what prevents osteoporosis. So this is a desirable bar. Increased breast density, which is this one, is really actually the biggest effect that tends to predict whether a person will get breast cancer or not. So when we look at the reason increased bone density might be a predictor for breast cancer risk, it's because people that have good bone density have tended to have more estrogen in their system, and we know that that increases the risk slightly. So these are the impacts that we look at having a relationship with breast cancer risk. So we know that flight attendants have more breast cancer. People with increased bone density have more breast cancer. People with increased breast density also have more breast cancer. And so that's been a helpful way for me to think about it from a relative risk standpoint to say, well, is taking hormones over here going to be something that even really stacks up against these other things that are more common or certainly more impacting risks of causes for breast cancer, or seem to be correlated with increased incidence of breast cancer? Get to the next slide here. These are the events and symptoms that occur with taking a synthetic estrogen. And this study used synthetic estrogen mainly because it was also what was used in that very large trial of women where the headlines were so negative and people stopped using their estrogen significantly. In this case, this is looking at whether or not there's increase or decrease incidence of each of these different diseases or factors that would be negative predominantly in our health history. So across the board, I'm going to talk about each one. Deep vein thrombosis, which is a blood clot in our legs, actually increases. So you can see this is a positive number and these are negative numbers in the way this slide is done. So anything above the line is decreased by being on estrogen. Anything below the line is increased by being on estrogen. So in this case, we can see that deep vein thrombosis or blood clots are increased by being on estrogen. They're not increased in drastic numbers, but they do occur more. This would be like saying that 3 people out of 1,000 would have a blood clot in their legs if they took an estrogen replacement. In this case, this is more like saying 7 or so people would prevent their heart disease out of 1,000 if they have coronary artery disease. That would be prevented by being on estrogen. Stroke, I remember, you may know that I just said that stroke was sort of a dead even or wasn't really majorly impacted by estrogen, and you can see it's very close to the baseline. Diabetes risk is reduced by approximately 13 people out of 1,000 would be prevented from getting diabetes if they were on estrogen. And then fractures are reduced by being on estrogen. There would be about 8 less fractures per 1,000 people by being on estrogen. Breast cancer, just so I'll tell you why this might seem confusing, this is women on estrogen only. So if you recall on the previous slide, women who were not taking a synthetic progesterone but were taking estrogen had a reduction in breast cancer. So that's what's showing up here. All cancers have a reduction by being on estrogen, and total mortality, so death, is reduced by being on estrogen. If you look at the reduction of symptoms by being on estrogen, we see that there's an extreme, this is out of 1,000 people, we'd see a reduction in symptoms of hot flashes or vaginal atrophy or dryness by utilizing estrogen. And so that shows us effectiveness of estrogen specifically for those symptoms. And currently, the guidelines now around hormones for women say that estrogen is a good medication to prescribe for hot flashes, and it's a good medication to prescribe for vaginal atrophy or vaginal dryness. The verdict, so to speak, from sort of the entities that make big statements about hormone use, like the American College of Obstetrics and Gynecology, or the Hormone Societies, or the Menopause Society of North America, each of those say that they recommend the use of hormones for short periods of time. And I actually take issue with that, because I look at these benefits of estrogen here and I say, why would I not want these benefits for my entire life? We know that it's not that the benefits go away after 10 years. We know the benefits actually continue. So the cancer reduction for all cancers actually stays. And on estrogen alone, the cancer reduction stays for breast cancer. Fractures, that reduction in risk stays lifelong. Diabetes reduction in risk stays lifelong. Coronary artery disease risk stays as a benefit in a lifelong way. And so when we look at why we would or wouldn't continue these for our entire lives, I have advised most of my patients that if you're doing well, we can stay on them. If a person is very afraid and wants to taper off of the hormones, we can try that. And we do that in little tiny baby steps so that we see what happens as we reduce the risk, reduce the dose, because the risk of hot flashes goes up quite significantly if we drastically do a cold turkey stop. I'm going to go back to just our pictures on the screen, unless someone has any other questions specifically about a slide, but I want to actually take some questions and dialogue a little bit about what we're talking about, because I think it may make it a little more relevant if we take some individual questions about, experiences or questions with hormones. In essence, utilizing hormones to balance to a level that is not trying to restart periods and not trying to even mimic the same level that we had when we were having a menstrual cycle, but really actually to give us the benefits. All of those benefits of estrogen that you saw in the slides were provided by doses that were approximately 1/4 what our typical level would have been when we were having periods. So when we were having periods, our estrogen level really ranged between 20 and 500 picograms. And when we give women hormone replacement, we're trying to achieve a level somewhere between 40 and 100 picograms. So we're really at the very lowest level like we had when we had periods because of those health benefits that we've talked about. But I want to open up for questions. And if there's something that you have a question about, please ask it, because often we benefit from asking questions so other people can even hear those same things. I'm going to unmute everybody, so if you have a question, you're welcome to ask it. And it may be that you have me, it's possible that you will have to unmute yourself if you've put it on mute on your own computer.
It's asking permission.
There you go. Thank you. And you don't have to give it if you're in a place that's noisy and you don't want to unmute. One of the things I said I would come back to was about blood clot risk. And this is one of the reasons that we have to be careful about hormone use. Estrogen, particularly if it's taken by mouth. So if I swallow a pill of estrogen, either as a birth control pill or as an estrogen replacement, even a bioidentical, even an estradiol pill, will be absorbed in such a way that the majority of it gets into the liver in kind of like a big punch. I think of it like as if I just dumped all that estrogen into the liver. And when that happens, it has an impact on our blood clotting. And so the liver is responsible for making blood clotting factors, and estrogen is able to work on that system creation and make us more prone to making blood clotting factors. So there is a risk of blood clots. It's not a high risk, but it is a significant risk of blood clots in women who take oral estrogen. In young women on a birth control pill, it's a couple women per 1,000. In women who are on a hormone replacement therapy afterwards, it's lower. But the thing that really is different about blood clotting risk is the way that you take your estrogen. So if you didn't take your estrogen as a pill, if you took it as a patch on your skin, a cream that you rubbed into your skin, an insert that stayed in the vagina, a drop under your tongue, or a troche that goes in the side of your mouth, or even a spray that you spray on your skin, all of those methods, because they're going through your skin or through your mucous membranes, do not have the impact at the liver and therefore don't impact blood clotting. And so they've been deemed safe for anyone, even with clotting risks. There are things we can do in someone who has a high history of a blood clot, in that we can also put them on something like a baby aspirin a day, or a vitamin called nattokinase that has a beautiful impact of preventing blood clots in the system with no side effects. Those are options to use in people who have a higher propensity to clotting. And then I always make sure that we have used a non-oral estrogen. One of the genetic tests that we're learning a lot more about, I do this genetic test in every person I do the cognoscopy brain evaluation on, is MTHFR. And MTHFR is a detoxification gene it works predominantly in our liver detoxification. If we have a mutation in that gene, it can't use folic acid appropriately, and we can't detox as well, and we have a higher risk of blood clots. So anyone with an MTHFR mutation, if you come to know that information about yourself, should not use an oral estrogen. And also, I would give you big cautions about a flu shot, because you can't detox the flu shot well if you have that mutation. And actually any vaccination, but in particular, most adults, it's the flu shot we're talking about. So there's adjustments that need to be made based on your individual health history when we pick an estrogen, or when we decide to initiate hormone therapy. But certainly, please feel free to ask a question if you have one. Otherwise, I have lots of things I can keep talking about, but I like to know if we're on the right track, or if there's anything that I can answer for any one of you.